On behalf of the New York ACP Wellbeing Committee, welcome to the second session of Wisdom and Wellbeing, Making Healthcare Work Better for Physicians and Patients. Thank you for joining us. I'm Lou Snitkoff, a committee member and an ACP Wellbeing Champion. This series is intended to explore important characteristics of the healthcare ecosystem that affect physician well-being and professional fulfillment. This session will address critical issues surrounding substance use disorders. So it's my pleasure to introduce our New York ACP colleague and content expert, Dr. Kelly Ramsey. I've been instructed to be brief, so I'll be brief. And just say throughout her career, Dr. Ramsey has dedicated her professional efforts to caring for vulnerable and underserved populations. She's also an ACP Wellbeing Champion and has served on the New York ACP Council Board and several chapter committees. Thank you, Kelly, for all you do and for spending time with us this evening.
Thanks so much, Lou. So I'm going to share my screen, and you'll see by my slides that, oh, hang on, let me get back to the beginning of the presentation. You'll see from my slides the template that it has New York State OASIS on it, which is the Office of Addiction Services and Supports. I'm the Chief Medical Officer for that state organization, which oversees the SUD treatment system in New York State. So I didn't want you to wonder what that was all about. So I was asked to discuss substance use disorders, our colleagues, ourselves. I do not have any financial relationships, and I wanted to start with a very brief case scenario that I just want you to think about throughout the presentation. So this, a 34-year-old physician, HM, is an established patient in your practice. HM presents for a follow-up visit after finishing inpatient treatment for opioid use disorder. Your patient shares that 6 weeks ago, they were approached by their medical director to discuss concerns from the clinic staff about HM's behavior, which included late arrivals to work, unexpected absences, mood swings, and weight loss. After the meeting, HM agreed to an evaluation by a physician health program, or PHP, and an opioid use disorder was diagnosed. Inpatient treatment was recommended, and HM is still on a medical leave of absence. HM is currently prescribed sertraline, 50 milligrams by mouth daily, and buprenorphine, naloxone, name brand Suboxone, 8 milligrams/2 milligrams sublingually daily. HM's aftercare plan includes attending community recovery meetings, focusing on self-care and spending time with their spouse and children. HM reports feeling better than I have in years and states that they have no cravings for opioids. The patient is attending cognitive behavioral therapy sessions for the treatment of depression and opioid use disorder and is enrolled in the New York State PHP. So as an internal medicine physician, what role do I play in supporting HM's recovery from substance use disorder? So our learning objectives are to discuss the vulnerabilities and risks for substance use and substance use disorder. Now that is a talk in and of itself, so I'm going to be going rapid fire through my slides, but I erred on the side of being more rather than less comprehensive because you will have access to the slides because I want you to have the ability to go back and look at them in more detail. Discuss what physicians should know to take care of themselves, discuss what physicians should know to take care of their peers, and discuss what physicians can do for their practice or organization. So first, let's talk about the vulnerabilities and risks for substance use and substance use disorder and epidemiology of substance use in physicians. So first, a quote from Sigmund Freud from Uber Coca from 1884. A few minutes after taking cocaine, one experiences a sudden exhilaration and feeling of lightness. One senses an increase of self-control and feels more vigorous and more capable of work. So very briefly, as I said, this is a talk in and of itself. When we talk about the pathophysiology of substance use disorder, it really has three phases. There's the binge intoxication phase, which is primarily focused driven by the basal ganglia. There's the withdrawal negative affect phase, which is primarily located in the extended amygdala. And then there is the preoccupation anticipation phase, which is governed by the prefrontal cortex. So substance use disorder is a very complex disease that affects multiple areas of the brain and has not only anatomical and physiological components, but as well has an emotional component, an environmental component, a genetic component, et cetera. So very complex. And we don't have the time to go into all the details of that in this very brief talk. Just a reminder how we diagnose substance use disorder. We use DSM-5 criteria. At least 2 criteria must be met within a 12-month period. However, that doesn't mean you can't treat someone if they have not had substance use disorder for a 12-month period. Because think about the current opioid epidemic and the risk for overdose. Obviously, we would not turn somebody away for treatment for substance use if they had had substance use for less than 12 months. But this goes through the criteria that someone needs to meet. It's done on a continuum of severity. So if someone meets criteria of 2 to 3 criteria, they have a mild substance use disorder. 4 to 5 criteria, a moderate substance use disorder. And if they have 6 or more symptoms, they meet severe substance use disorder criteria. The vast majority of patients that came into care with me had severe opioid use disorder at the time that they came into care. This is a list of what I consider the most prominent vulnerabilities for developing substance use disorder in the general population. So genetic predisposition is a huge component of that risk for developing substance use disorder. Depending on the substance, anywhere from 40 to 60% of the risk, and even higher for cocaine, for instance. So again, if there's any family history of substance use disorder, regardless of the substance, that puts someone at risk for developing a substance use disorder. Concomitant mental health diagnosis, these risks are not uniform across mental health diagnoses, so particular diagnoses confer more risk. Particularly bipolar disorder, any form of anxiety, major depression, ADHD, and specific personality disorders such as borderline personality disorder and antisocial personality disorder. A history of trauma is very significant in the development of a substance use disorder. So for example, particularly significant in my patient population, really almost 100% of my female patients was pre-adolescent sexual trauma. Also the victim or witness to violence, and this is in males or females. Often people have poor coping mechanisms and they may seek substance use to escape. Impulsivity plays a part, particularly in initiation of substance use. Impulsivity is associated with some of the mental health diagnoses that I already mentioned, such as bipolar disorder and borderline personality disorder. And also impulsivity is associated with sort of not yet developing the prefrontal cortex or the frontal lobe. So we have an adolescent brain till we're about 25 years old. So if people initiate substance use earlier than that, that actually affects the neural pathways in the brain, both from an anatomical perspective. In other words, neural circuits are changed to reinforce pleasure and the dopamine surges that you get with substance use. And the physiological balance of neurotransmitters is altered as well. So it sort of primes the brain to seek reward and seek pleasures that are not physiologically normal with things that don't involve substances. Also, another thing that I think is under recognized is the role that environmental triggers and sensory cues play. So for example, if someone sees a bag of heroin, their brain has already led them down the pathway to resume use before they're even conscious of that craving, just to give one example. I'm not going to go deep into trauma because I know the last presentation covered trauma, but it's very important to understand trauma and its role that it plays in presenting vulnerability for people to develop a substance use disorder. And again, that does not have to be actually experiencing the event themselves. It could be witnessing the event that happens to someone else. It could be learning that that event happened to a close family member or friend, or it could be experiencing repeated or extreme trauma to aversive details of such an event, such as first responders or the entire medical system during COVID-19. That response to trauma often, or to witnessing violence, often leads to actual, again, anatomical and physiological changes in the brain. Trauma is a whole talk in and of itself as well, so I'm just hitting the highlights here. So trauma's effects are significant on behaviors that people may develop to cope with trauma, as well as impacts on physical and mental health. And the other thing I always throw in this slide about intersectional identities, because again, we are physicians, but we have many intersectional identities in our lives that may play a role in how trauma impacts us individually. So also there's a very significant risk between trauma and addiction. So when trauma happens to individuals, often in response to that trauma, people will use substances to cope with the trauma that they've experienced. So it can put people in dangerous situations and certainly lead to effects on their health status. And often individuals with substance use and or substance use disorder experience multiple additional traumas due to their substance use. So on the right-hand side, I put some normal responses to prolonged stress and crisis. And so this could be a persistent anxiety or feeling what they term as revved up, irritability, reactiveness, hypervigilance, guilt, feeling overwhelmed, sleeping problems, increased emotionality, difficulty focusing, etc. All of these are normal and a normal response that we would expect to stress, but often those symptoms are intolerable to individuals, and that may lead them to adopt additional coping mechanisms, which may include substance use. The other thing that I have to put in any talk I do about substance use is to talk about stigma. And stigma, again, is also a talk in and of itself. But what I wanted to point out is the stigma that exists in healthcare settings towards people with substance use disorder diagnosis, active substance use, mental health diagnoses, as well as in some venues, HIV and hepatitis C, as well as other diagnoses. So what I think is most important to emphasize is that stigma contributes to suboptimal and sometimes traumatic healthcare experiences and health outcomes. And what it can do is limit a person's ability to access or even to desire to access services because of the fear of being stigmatized. So we also need to recognize that relationship between stigma and trauma. So we've talked about how trauma can lead to riskier behaviors, and stigma also leads to riskier behaviors. And often people, to cope with stigma that they've experienced, will adopt high-risk behaviors as a way of coping both with the stigma and the trauma. So a little bit of epidemiological data. So these are from the National Survey on Drug User Health from 2020, and this is on SUD and mental health comorbidity, and I'm just going to dwell on this for just a moment. So in the top of the left-hand side, it shows the interface between adults with substance use disorder, and AMI is any mental illness, so any mental health diagnosis. So you can see that among people with a mental health diagnosis, there's a proportion that has also a concomitant substance use disorder. However, if you look at the substance use disorder population, it's a larger percentage of that population that has a concomitant mental health diagnosis. So again, depending on your clinical setting, you may have a much higher percentage of your patients with a substance use disorder who have a mental health diagnosis. In my patient population that was in an FQHC, it was about 80% of my patients with an opioid use disorder diagnosis had at least one mental health diagnosis. On the bottom is looking at the population with SUD and an SMI, which is a serious mental illness. You can see here that it's a smaller population of those with a serious mental illness who also have a substance use disorder. On the right-hand side is kind of showing you that relationship between any mental health diagnosis, a serious mental health diagnosis, and a person who has no mental health diagnosis. The more significant your mental health diagnosis is, the more likely you are to be using substances. And you can see that goes across the board regardless of what substance we are discussing. So let's talk about some additional vulnerabilities for developing substance use disorder in physicians. So clearly they have the same vulnerabilities that are listed on the slide that I did for the general population, but they also have some unique vulnerabilities. And these are stereotypes, granted, but just to make some of the points, I thought it was important to include this. So we have greater access to prescription medications than non-physicians, and we have the ability to write prescriptions. We have higher work stress, particularly during COVID-19. I have a lot of cats, so please forgive me if they're jumping in the picture. We also have a culture of medical care and behaviors modeled in physician training that have been faulted for promoting attributes that can interfere with physician wellness or obtaining clinical care for oneself as a physician. So what are some of those attributes? Early assumption of responsibilities, trained to be self-reliant and self-sufficient, and this may even lead, in the worst case scenario, to self-treatment. Confidence in understanding medications may lead to self-diagnosis, self-medication. The ability to perform under stress and despite personal difficulties is a hallmark of our profession. And physicians often have sophisticated denial with elaborate justification and rationalization, making intervention potentially more difficult. And we may be better at concealing use than others do because we're often high performing. And again, take this all with a grain of salt, but professional arrogance, or you can frame that as overconfidence, can lead to difficulty taking directions or input from others. And gender may be an issue as well. So research studies suggest that female physicians with a substance use disorder are not referred to treatment as frequently as male physicians. There's also, generally speaking, in female physicians as well as females in the general population, what we call a telescoping effect, which means that women have a quicker progression to unhealthy use and consequences due to their use than do men. So let's look at just some general epidemiological data of prevalence of substance use disorder among physicians. So these were several studies that I looked at. So there was a study in 2012 that looked at over 7,000 physicians, again, about a 29% response rate. They found that about 15.4% scored positively on the audit C, suggesting the presence of alcohol use disorder. Those numbers aren't too different from the general population. A 2015 study of 7,200 physicians of various specialties, about a 27% response rate, showed 21% likely had a substance use disorder, either alcohol and or other substances, based on screenings that they had done. They used the WHO screening as well as the audit C. So alcohol has been found to be the most frequently misused substance in several studies that have been done in the United States with physicians who have substance use disorders, and prescription opioids is usually the second most frequently misused substance. Physicians have been found to have higher rates of prescription drug misuse, notably benzodiazepines and opioids, compared with the general population, and that again has to do with access. And often they are self-prescribed or obtained through other professional access routes. So if we look at substances of choice, this was a sample taken from a physician health program of over 3,600 physicians between 1980 and 2002. So just a footnote, some of the studies are a little older. So I'm using both current and older data to try to give you a rounded view. So this was done between 1980 and 2002, and they asked physicians who had a substance use disorder enrolled in a PHP, what were their drugs of choice? So it was alcohol for 25%, equally with opioids for 25%, marijuana 12%, cocaine 11%, sedatives 10%, which would represent benzodiazepines, amphetamines 4%, inhalants 1%, and other 8%, and they did not specify what the other was. In looking at trends over time, it does look like the number of physicians assessed for and treated for a substance use disorder has increased in recent years, but also I think that's just a bias due to increased awareness of substance use and substance use disorder. So that may be skewing those numbers a little bit. So here's where I go. I'm going to go into a lot of studies, and we just don't have the time for me to go through each aspect of the study. So what I'm going to do is kind of focus more on the conclusions of the study. All my slides have references, so you can go back and read the details of the slide, as well as have access to all the initial study that I pulled it from. So this one was a national study looking at substance use disorder in a large sample of US physicians from a variety of disciplines. And they use validated instruments to diagnose substance use disorders. What they found was, and they're I'm very particular about language, and they're using DSM-4 language rather than the current DSM-5 language. So when I use the words abuse and dependence, those are from DSM-4 criteria, which is not how we currently define substance use disorder. But based on over 7,200 physicians who completed surveys, what they found was that 12.9% of male physicians and 24.1% of female physicians met diagnostic criteria for what we would now call alcohol use disorder. In this particular survey, misuse of prescription drugs and use of illicit drugs was rare. They did identify some risk factors specifically for alcohol use disorder. They had to do with hours worked, male gender was actually protective as opposed to female gender, being married or partnered or having children was protective, being married or partnered was not, and being in a specialty other than internal medicine was a higher risk. So just the conclusion in this study was that alcohol use disorder is a significant problem among American physicians. And since prognosis for recovery of physicians from, again, old term chemical dependency, I would now say substance use disorder is exceptionally high. Organizational approaches for the early identification of problematic alcohol consumption, followed by intervention and treatment, should be strongly supported. So what about if we look at comorbidities among physicians with SUD? So what do those look like? So just as in the general population, the prevalence of co-occurring mental health diagnoses in physicians with a substance use disorder is high. There's a wide range of estimates, anywhere from 25 to 70%, 75% would have that comorbidity. So this was a study looking at almost 100 physicians who had completed a PHP diagnostic evaluation in Florida. And they found that 30% had major depression, 11% bipolar disorder, 7% antisocial personality disorder, 7% generalized anxiety disorder, and 5% social phobia. In another study in a Virginia PHP, they found that 33% had bipolar disorder, 24% depression, 9% antisocial personality disorder, and 9% generalized anxiety disorder. And what they found in the Washington PHP was that a coexisting psychiatric disorder, along with your substance use disorder, puts you at higher risk for return to use. So what about if we look at clinical specialties? What information do we cull there about do certain specialties confer higher risks? So we do see addiction across medical specialties, but there do appear to be higher rates of substance use disorder among physicians in anesthesiology, emergency medicine, psychiatry, and family practice. Pediatricians typically have the lowest rate of addiction in any studies. So the use of specific substance classes varies across medical specialties. Emergency medicine residents, for instance, reported higher rates of cocaine use compared with other specialties. Rates of marijuana use were higher among physicians in emergency medicine, family medicine, anesthesiology, and psychiatry. Psychiatry had the highest use of benzodiazepines, and female surgeons had the highest rate of alcohol use among female physicians. Anesthesiologies are also much more likely than other physicians to use drugs via injection or intravenously, and to misuse specifically opioids and propofol. Again, they have higher proximity to and access to these medications. So, which came first, the chicken or the egg? Do they develop substance use with these particular substances because of access, or are people with a predisposition towards substance use more likely to pursue anesthesiology as a specialty? So this next study, again, is looking at clinical specialties, and this looks specifically at the physicians following completion of training in anesthesiology. And this was a long study from 1977 to 2013. And they found that it was a significant risk to develop substance use disorder, particularly with opioids, among anesthesiologists. And the conclusion was particularly alarming in that a substantial proportion of anesthesiologists who develop substance use disorder after the completion of training die of this condition, and the risk of return to use is high in those who survive. So training, meaning that they die due to unintentional overdose. So what are some of the clinical manifestations of substance use disorder among physicians? So some of these manifestations are similar to the general population, but then there are also some manifestations which are unique to physicians. So changes in mood and affect, which could be depression, mood swings, blunted affect, irritability, etc. Decreased productivity, tardiness, absenteeism, frequent breaks, missed appointments, increased mistakes, medical errors, charting errors, impaired judgment, inconsistent hours, rounding at variable times, unexplained disappearances, taking extra shifts, especially at night, complaints from patients, colleagues, supervisors, or lawsuits, evidence of diversion, so missing or broken vials, failure to document appropriately, extra attention to patients receiving misusable medications, inappropriate prescribing, deterioration in appearance, disheveled, poor hygiene, wearing long sleeves in hot weather, deterioration in physical health, flu-like symptoms, perhaps oversedation, watery or bloodshot eyes, weight loss or gain, lack of coordination or tremors, changes in social interactions, changes, so social withdrawal, increased conflicts, excessive drinking at events, inappropriate behavior, legal issues such as arrests or DUIs, and suicidality. So this I thought was particularly important to share, that suicidality, so whether that is by intentional overdose, or suicidal ideation, suicide attempts, etc. So suicide rates among physicians are higher than the general population, and rates among female physicians are particularly concerning. In one meta-analysis, rates of suicide were 70% higher in age-matched males and 250 to 400% higher in age-matched females compared with the general population. So I found that statistic particularly alarming. So what about the course of substance use disorder in physicians? What does that look like? So it doesn't really differ very much from the general population, but the length of time before recognition of an active substance use disorder in physicians may vary by the substance used. So for example, it might progress more slowly with alcohol and it might progress more quickly with opioids, just to give one example. So often physicians who develop a substance use disorder began to use illicit substances or alcohol excessively prior to medical school. And what they found is that in this particular PHP survey that they did, there were high rates prior to medical school for many of the individuals who participated in the PHP. So alcohol over 90%, other substances almost 65%, and tobacco 73%. And other occupational risk factors for developing an SUD could be evident as well as early as medical school, again, due to increased access and higher levels of stress. So this was a survey that was done with over 4,400 medical students, and it found that 34.5% believed it was acceptable to self-prescribe antibiotics. Almost 58% believed it was acceptable to prescribe for a spouse. Students who had burnout were more likely to find these prescribing behaviors acceptable and less likely to believe that they have a responsibility to report impaired colleagues. And medical students who had elevated audit C scores suggesting an alcohol use disorder were less likely to believe that they had a responsibility to report a colleague who was impaired. So this one is looking at risk factors for, I don't like the term relapse, but that was the term the study used. I say return to use or resumption of use. Relapse can be stigmatizing. So this was risk factors for return to use in healthcare professionals with substance use disorder. Again, for the in the nature of our time, I'm going to focus on the conclusion of this study, which is that the risk for return to use with substance use was increased in healthcare professionals who used opioids and had a coexisting psychiatric diagnosis and or a family history of substance use disorder. The presence of more than one of these risk factors and a previous return to use further increase the likelihood of return to use. So again, just kind of showing the complexity of substance use disorder and why our patient in our case at the, oops, I don't know what happened there. Why our case at the beginning was a very unusual case. It was a perfect patient. So this study was looking at physicians and nurses with substance use disorders, and in many areas of study, nurses and physicians have comparable results for the course of their substance use disorders, but there were some statistically significant differences between these two groups, and that may impact policy. So in a little bit, I'm going to go over the PHP program as opposed to the PAP program, and I'll talk about what those acronyms mean in a few minutes. So we may need to do a better job of supporting our nurses. We're doing a pretty good job supporting our physicians. The next section I'm going to move into is the impact of the COVID-19 pandemic on mental health and substance use. Again, for the sake of brevity, I'm going to go quickly through these slides. These were perceived COVID-19 pandemic effects. So this was people being asked if they had increased their substance use and or their alcohol use. So you can see it's a small minority who thought that they increased use, but it's a significant but small minority. And that is regardless of the age group that we talked about. Most people thought that they used substances about the same as prior to COVID-19. This is looking at the negative effect on emotional or mental health of adults 18 and over on the left-hand side. And obviously you can see that individuals who have any mental health diagnosis or a serious mental health diagnosis had significantly more negative effect of COVID-19 than those, for example, that did not have a mental health diagnosis. And on the right-hand side is looking at the negative effect on mental health services for those 18 and over who received services. And in this slide, you can see that people had some delays in getting prescriptions, or a small proportion were unable to access care that they needed that they felt like resulted in worsening mental health. Briefly, we're going to just talk about the overdose epidemic that's going on. And if you look at the slide on the right-hand side, it's showing you from September 2019, so 6 months prior to the pandemic, to the first 6 months of the pandemic, September of 2020, we had a 55% increase in synthetic opioid overdose deaths. So that's due to illicitly manufactured fentanyl and its analogs, but also a 30% increase in overdose deaths due to cocaine and a 46% increase in deaths due to methamphetamine. So again, just a reminder that through December 2021, we had over 107,000 people die due to overdoses. So this is 2/3 due to synthetic opioids such as illicitly manufactured fentanyl and its analogs, but not very important not to forget that many overdose deaths are related to stimulant use. So again, anyone using any illicit substances is at risk for overdose. This is New York City and state specific data. So you can see that rise from 2015 to 2021 on the left. So looking at it over time, and then that significant increase of 139% for the data in 2021 from overdose deaths in New York City. A reminder that deaths were not due just to overdoses. So there were significant alcohol-related deaths due to COVID-19 as well. And then for folks who were concomitantly using opioids and alcohol, there were very significant increase in overdose deaths. So again, that it's really across the board with substances. So we know that there were significant mental health impacts of the COVID-19 epidemic across many groups. Again, I'm not going to go into the details, but these are studies that looked pre-COVID and during COVID, and there were very significant increases in decrease in overall mental health well-being, increase in stress, increase in anxiety, and increase in depression. And so while the entire population was impacted by the effects of COVID-19, there were disparate impacts due to COVID-19 in different populations. So there was significantly increased vulnerability for mental health symptoms, substance use, and suicidality in youth, particularly 18 to 24 years old, women, racial and ethnic minoritized communities, individuals with lower incomes and less money in savings, individuals who were homeless, and older adults. Lastly, in healthcare workers. So among healthcare workers, increased job-related anxiety went up from 1 to 27% early in the pandemic, and increased generalized anxiety disorder logged in at 15.8%, an increase in depression, 14%, and PTSD of 23.1%. So we saw very early in the pandemic that there were increases in substance use. In the general population, it went up 13% in the first 3 months of the pandemic. And we also saw significant changes in substance use disorder treatment, which was forced to pivot very rapidly when the pandemic struck, particularly in New York State as the epicenter. So what happened to physicians, and what is the impact of COVID-19 on physician burnout globally? So again, just for the sake of time, I'm going to have to focus on the conclusions here, but this was looking at physician burnout, trying to understand what the factors or potential factors were contributing to burnout among healthcare professionals during the pandemic. So they showed that some techniques such as mindfulness may help relieve burnout, but that a small number of studies focusing on physician burnout amidst a pandemic, we really don't have a lot of conclusions. This is something new, so I think we don't quite know yet on how best to deal with our burnout during the pandemic. This came out of England, and this was looking at morale among doctors in the UK, which suffered significantly. So they had a prevalence before the pandemic that was much lower, but they found that during the pandemic, burnout was between 66 and 80% among physicians, and that 48% of doctors were considering leaving the pandemic when surveyed about their likelihood to stay active being a physician. So we need to consider that moral injury and trauma that has occurred in our profession, and the impact that that has on physicians and their coping mechanisms. This again looked at the impact of physicians' COVID-19 pandemic occupational experiences on mental health. And this was looking at the association between anxiety, depression, and PTSD among physicians. And what they found were that there was increased anxiety, increased depression, and increased PTSD among physicians. So 23% increase in anxiety, 23% increase in depression, 41% increase in PTSD. So that these negative pandemic experiences clearly had adverse mental health outcomes, and if people had greater resilience, then that was protective from some of these negative outcomes. This is looking at the COVID-19 crisis and impact on the next generation of physicians, and this was a survey of medical students. And what they found here was that 82% of these medical students volunteered to continue their internship or be reassigned to COVID units. And what they found was that, interestingly, 93% of those that volunteered in COVID-19 units half acted as nurses. It did reinforce their commitment to become physicians, but at the peak of the outbreak, 17% had doubts about their ability to become physicians. 12% reconsidered their choice of specialty. 38% scored 7 out of 10 on a sadness scale, and 43% scored 7 out of 10 on an anxiety scale. So again, it's having an impact on our trainees as well. Their conclusion here was that the vast majority remained convinced that they want to become physicians, but the experience had a significant psychological cost, specifically and especially for women. This looked at sleep disturbances. There are several studies that talk about sleep disturbances, both among physicians and nurses during COVID-19. So again, our frontline workers are often having the harmful effects, not only of scheduling interfering with sleep, but also sleep disturbances due to these mental health effects that I've talked about and the repeated exposure to trauma. These two studies, one again looked at depression and anxiety and stress. The other one looked at insomnia and stress. Very similar results to the two previous studies that I presented. So again, I have all the details here for you with the references, but for the sake of time, I'm not going to go through those details. So if we look at what is the impact of COVID-19 on physicians, this came from a couple of surveys that were done. So what about on their practices and their patients? So 8% of physicians said their practices closed as a result of COVID-19, so about 16,000 practices. 4% plan to close their practices within the next 12 months. 43% have reduced staff due to COVID-19. 72% have experienced a reduction in income due to COVID-19. 12%, or approximately 100,000, switched to telemedicine due to COVID-19. 52% plan to increase use of telemedicine. 72% have indicated that COVID-19 will have serious consequences for patient health in their communities. With respect to physician burnout, 58% experienced often feelings of burnout compared to 40% in 2018. 22% of physicians know a physician who has committed suicide. 13% have sought medical attention for a mental health condition. And 37% would like to retire in the next year. So this was a very good article that looked at the intersection impact and interventions with respect to COVID-19 pandemic and the burnout and PTSD in physicians. And this looked at it contrasted burnout in PTSD, looking at symptoms and consequences and interventions. And the interventions, the symptoms can be similar, as can some of the consequences, but the interventions are quite different. And so we know this because we're here for this well-being series, but what we need to do is help our organizations recognize the interventions that are needed to affect burnout in physicians, particularly with the added impact of COVID-19. So what do physicians need to know to take care of themselves? So first of all, it's important that if you think you have an issue with alcohol or other substances, that you ask yourself a few questions. Am I spending less time on activities that were once important? Am I using more alcohol or other substances than intended? Am I having a stronger desire to drink or use substances to wind down from my day, for instance? Have I unsuccessfully attempted to stop using? Am I experiencing problems that are caused or worsened by my use? Am I continuing to use despite problems? Am I experiencing a change in my tolerance? Am I using substances in different and dangerous situations? This could include driving. Am I failing to fill my obligations? Am I experiencing withdrawal symptoms when I don't have access? Am I spending more time around substance use? Again, these are the DSM-5 criteria, but it's important that we recognize it in ourselves. So what can we do and what should we know to help us take care of our peers? So first, a quote: "The onus cannot fall only on impaired physicians to heal themselves. Physician colleagues and supervisors need to reach out to them." This comes from the Well Toolkit from 2020, and I put the link there. So back to our case scenario really briefly. So as I've demonstrated in the epidemiology that I shared, physicians have substance use disorder at about the same rate as the general population. So the estimates of prevalence among physicians are about 10 to 15%, which is very, very similar to the general population. As I mentioned, alcohol use disorder is the most common substance use disorder among physicians. Female physicians are particularly at higher risk for alcohol use disorder than their male counterparts. We talked about that there is some variation among specialties as far as the frequency that we see of substance use disorder among specialties. And we talked about some of the unique access and the unique differences between specialties and substances of choice. I talked about the risk factors for substance use disorder for physicians, including high levels of work-related stress and exposure to illness, trauma, and death, and often untreated depression or other mental health diagnoses. But the good news is that physicians can recover from their substance use disorders and achieve stability with respect to their substance use disorders, similar to other individuals, and can often continue their careers in medicine. So, how do we recognize substance use disorder among our colleagues? So we have an important role to play. It's important, just as we are observant with our patients, that we are observant with our colleagues. So reports to physician health programs, or PHPs, come from many, many sources with a concern about an impaired physician, including patients, families, hospital staff, coworkers, peers, and the legal system. So if you suspect that a physician colleague is misusing substances, it is not up to you to intervene or try to establish or confirm that diagnosis. That should happen with a professional evaluator from a PHP, but it's important for you to note and document behaviors and events that indicate possible substance use. And what are the responsibilities of our colleagues? So it is important to report a colleague or a friend with a suspected substance use disorder to a PHP in New York State, and I'll give you that information in a minute. And I'll talk about the difference between reporting to a medical board versus reporting to a PHP. And many physicians are reluctant to report their colleagues, even if they suspect they're impaired or potentially incompetent, and they want to avoid confrontation. But that quote unquote conspiracy of silence has the potential to cause harm by allowing that physician to potentially practice while impaired. So we do have a duty to report to our patients, really, and to ourselves and to our organizations, to report potentially affected colleagues. And some ramifications of not intervening include putting the physician's patients at risk of harm, subjecting yourselves to potential professional or legal sanctions, denying the physician an opportunity for treatment, and the long-term impact of that substance use disorder on the physician's family and career. So what are the reporting requirements in New York State? I put the links there that are important for you to be familiar with. So all licensed health professionals are required by state law to report colleagues whom they suspect may be guilty of misconduct, and failure to report suspected instances of misconduct is in itself misconduct. So if you believe a colleague's actions may constitute misconduct, you contact the OPMC. However, with respect to physicians who have substance use and or substance use disorder or mental health issues, they may or may not be impairing their practice with their diagnosis. So it is very appropriate to report them to the Committee on Physicians' Health, which is our PHP in New York, which is run out of MSNY, or the Medical Society of the State of New York. Our report is confidential, and the CHP, the medical director of the CHP, is one of my colleagues from NISAM, and he is a psychiatrist and addiction psychiatry specialist. So this is a person who has the skill set to evaluate someone to determine, A, if they have a mental health diagnosis or a substance use disorder diagnosis, and B, is that diagnosis actually impairing their ability to be a physician? So what the law says is that practicing the profession while impaired by alcohol, drugs, a physical disability, or a mental disability is a problem. And if it impairs the practice, then it is a problem, not the diagnosis in and of itself. So I encourage you to go to these statutes and these websites to see the specific language. So how do you report potentially impaired physicians in New York State? You contact the Committee for Physician Health, or CHP, Anyone can make a referral to them. Most referrals, 75%, come from colleagues or physicians seeking help from themselves, nurses, other healthcare professionals, workers, friends, and family members who are concerned. If you call them, then as I said, that's a confidential phone call. The referral source for that referral is never identified unless you as the caller agree to be identified. And once the referral is made, the program staff gather information and meet with the physician who may have the impairment to determine what steps are necessary. This is all confidential, and this Committee for Physician Health does not refer physicians to OPMC as long as the physician agrees to participate in the program, stays with the program, is helped by treatment, and does not present an imminent danger to the public. Again, the OPMC is a different office that is run out of the Department of Health. And if you wanted to file a complaint about somebody, I put the information there. So what are some barriers to seeking help for physicians with a substance use disorder? So again, we're going to focus on the conclusions here, but there's similar barriers to folks that are in the general population. So stigma plays an enormous role in people not seeking care. And that includes stigma towards physicians with substance use and or substance use disorder. So, fear of that stigma can certainly prevent some physicians from getting help, even though there's increased awareness around substance use disorder today. So this was a study that looked at the 5-year outcomes and efficacy of physician health programs. And, this was really good news. So about 3/4 of the physicians who were part of a PHP had favorable outcomes at 5 years. So physicians are a particularly high achieving group. So again, their outcomes are not generalizable to the general population. We do not have that high of a success rate in the general population, but physicians have a lot of motivation to succeed. And what these programs do is they provide not only medication treatment, but they provide counseling and other supports that are needed. And typically physicians, unlike the general population, are followed for 5 full years. So that's very helpful for supporting physicians who may be vulnerable to return to use. So what can physicians do for their practice or organization? And I know we're coming up on time, so I'm going to lightning go through these slides. So just a quick quote: the misuse of drugs and alcohol by physicians is compounded by their critical role as caregivers. Historically, quote, addicted physicians either went unnoticed or were treated punitively. In 1973, the AMA recommended in a landmark report entitled The Sick Physician that state medical societies establish programs to identify and treat impaired physicians. Since that time, every state has established a program or committee for that purpose. So I'm going to point you to position papers that you should be aware of, and that sort of rounds out the comprehensiveness of this presentation. So ACP released a position paper in June of 2019 on physician impairment and rehabilitation, and essentially discussed PHPs and that they were kind of the gold standard for the treatment of physicians with substance use disorder. So CPH, this is a little bit more information on our version of the physician health program in New York State. So it's been around since 1974 in New York State. And again, I'm not going to go through the details because I already kind of addressed it, but this gives you a little bit more information. So interestingly, the PAP, or Professional Assistance Program, is where nurses and other licensed professionals are referred. That's separate from the CHP. And I'm going to give you a completely Kelly's biased impression of the PAP because they have called me into meetings and asked me to present before, and they are not where the PHP is at. They are anti-medication, including medication for opioid use disorder, which we know is life-saving. And they also use extraordinarily stigmatizing language when they refer to nurses who have a substance use disorder. So I'm hoping, and part of my role at OASIS is working with the PAP to help them become more up to date in in current treatments of substance use disorders so that nurses and nurse practitioners can benefit from the same treatment that physicians are getting. ASAM has quite a lengthy, so the American Society of Addiction Medicine has quite a lengthy statement on physicians and other healthcare professionals with addiction. I've included the key points here. This came out in February of 2020, and I have 2 slides that go through all the recommendations associated with that. And so again, I don't have time to go into those details, but I have it there so you can refer to it. The last point is what I highlighted. Healthcare professionals should be educated about occupational risk factors for addiction, given healthcare professionals' unique access to controlled substances and legal authority to write prescriptions. They should also receive training in healthy self-care and stress management practices to promote health and prevent unhealthy use of medication or drugs such as alcohol. Healthcare professionals should be able to recognize signs of addiction in colleagues and know how to help colleagues connect with non-disciplinary assistance. So the last several slides that I included are just kind of how to theoretically think about what we can do given the impact of COVID-19 on physicians with burnout and PTSD, and how these all intersect and how we can kind of promote more well-being among our profession. And so I included these slides just so you have them to look at. But again, we need a systems-based model that addresses PTSD due to trauma, COVID-19, and other professional stressors, as well as burnout, and try to create meaningful work, a psychologically and physically safe workplace, promoting humanism and diversity, and making sure that all of our individuals in our healthcare system have access to mental health resources and substance use resources without stigma. So I've included these slides on some things to just think about in our doing the work and how trauma impacts us as clinicians. Again, I'm just including these. These are some slides that the University SUNY Buffalo developed for OASIS for us to do with our workforce, the substance use disorder treatment workforce. And I really thought like they had cross applicability for us as physicians. So again, how do we think about neutralizing the environment? This offers some suggestions on how to do so by creating safety, trustworthiness, choice, collaboration, and empowerment among our physician workforce. So again, how do we change that narrative? We change that narrative by fostering resilience and having that lead to growth in response to an adverse event as opposed to impairment. And again, just for completeness, I included these slides. So again, one further slide on other suggestions on what we can do as a group, but I'm going to zoom in on the conclusion since I know we're coming up on time and I want to give a couple minutes for questions. So just some summary and recommendations. So physician impairment refers to the inability to practice according to accepted standards as a result of a medical or psychiatric issue, most prominently due to substance use and/or a substance use disorder. In the United States, physicians, as I've mentioned a couple times, have similar rates of substance use disorder as the general population, but higher rates of prescription drug misuse because of that access issue than the general population. Alcohol is the most frequently misused, again, with higher risk among female physicians. Anesthesiologists have a higher risk of opioid use than other physicians. Clinical manifestations are similar as they are in the general population. However, there are some unique factors that are just associated with the nature of our physician business. So diversion, lawsuits, decreased productivity, increased mistakes, or impaired judgment. Reports identifying physicians with an active substance use disorder to a PHP or a medical board come from many sources, as I mentioned, and physicians have a duty to patients and to their profession to report impaired physicians and to assist those with active substance use disorder who are not yet impaired. And in the United States, one source said 50 states. When I Googled it, it actually said only 47 states have a PHP. So I'm not sure, and the District of Columbia, but New York does. And that's the important thing that we're talking about here. But there are legal requirements for reporting impaired colleagues. Stigma towards substance use disorder, people who use drugs and substances themselves contributes to the stigma towards physicians with substance use or substance use disorder and their ability and willingness to seek care. And finally, my last point is that trauma due to COVID-19 has increased to an increase in mental health symptoms, substance use, and suicidality among physicians, and we have a responsibility to promote and support well-being, resilience, and growth. So my last slide, I just put my email, and if anyone has any follow-up questions after you digest this, particularly after you get the slides and review them, I'm always happy to chat with folks.